In this video, we will discuss the echo assessment and grading of aortic valve stenosis, especially focusing on the valve morphology and the key echo parameters you need to measure. Our objectives today are to review the assessment of aortic valve morphology, review standard transthoracic echo measurements for the assessment of AS, and discuss common caveats to echo parameters of aortic stenosis. To assess valve morphology on echo, the best view to look at is the parasternal short axis at the level of the aortic valve. You can get some information from the parasternal lung as well. For example, with some bicuspid valves, you can get leaflet doming or asymmetric closures, but you can also get asymmetric closures if the view is off axis. You don't want to be fooled, and you want to make sure that you're looking at your parasternal short axis. Sometimes with some patients, we have poor parasternal windows. And so another place to look, you can actually have a modified short axis in the subcostal views, and you can try to assess the valve there to enable to obtain good windows in the parasternal. The diagnosis is most reliable when the cusps are seen and assessed in systole, because when you're in diastole, you can have things like a bicuspid valve with a raphe that appear to be tri-leaflet. But once the valve opens, you see that some are fused and that you actually have a bicuspid valve. This is an illustration from Michelina et al. Showing the orientation of the cusps that we see on a short axis view. So the right, left, and non-coronary cusps. And this is the Siever's classification by Sievers and Schmidtke from publication in 2007, which helps us sort of classify the different types of bicuspid aortic valves. Type 0 would be no raphe, which is a true bicuspid valve. Type 1, which is the most common type, has one raphe. And as you can see, type 1 is subcategorized type 1A, type 1B, type 1C. Type 1A with fusion of left and right cusps is the most common type. And type 2 is a valve with two raphe, which is functionally unicuspid. Now, if you're looking at this picture and you're saying, hey, wait a minute, that orientation is a bit different from the illustration you showed me on the slide before, that's because this is the surgeon's view. So not to get confused, this is with the left coronary sinus on the left side, not the echocardiographer's view that we see in parasternal short axis. So to put something in perspective that we're more used to looking at when looking at echo, this is a figure from Kong et al., which takes that same Siever's classification, but reorients things in a way that we are more used to seeing with the orientation of the right, left, and non-coronary cusps. And this shows, again, the opening that is expected. This is an illustration from Baumgartner et al., which shows some of the different types of valve disease, three most common types. On the left, we have a normal appearing valve. Then we have what we see is a rheumatic appearing valve with fusion of the commissures between the leaflets, calcific valve, and a bicuspid valve. So let's have a look at some valves. It's a parasternal short axis view at aortic wall level, and three leaflets are clearly visible. So it's a normal tricuspid well-opening wall. Yeah, so this one's a little bit more challenging because it's not as well visualized. But what we can see here is that the opening appears to be more horizontal. So the opening looks like it's kind of a 3 o'clock to 9 o'clock opening. So this is probably a bicuspid valve. You also lose those kind of three nice sinuses of Valsalva that we saw previously, although it's not well visualized. So a little bit more background. Aortic sclerosis, thickening, degeneration of the valve, and stenosis, where do we draw the line? So stenosis is when your maximal velocity across the valve reaches 2 meters per second. And according to the 2020 ACDC AHA guidelines for the management of heart disease, they've classified aortic stenosis in different stages, stage A, B, C, and D, with subclassifications for C and D. Stage A is at risk of aortic stenosis. So these are patients with bicuspid or other congenital abnormalities or aortic valve sclerosis, but that Vmax, that maximal velocity, is less than 2 meters per second with enough leaflet opening that you're not generating these gradients. Stage B is progressive AS, and this incorporates both mild and moderate aortic stenosis. The mild stenosis is defined as a Vmax of 2 to 2.9 with mean gradients of less than 20. And moderate aortic stenosis has a Vmax of 3 to 3.9 and a mean gradient of 20 to 39. This is from the ASE 2017 guidelines for the assessment of stenotic valves. And if we look to the right of the table, we see those magic numbers that we all try to remember for severe aortic stenosis and good for junior trainees to learn. So peak velocity, so Vmax for severe, is when you've reached 4 meters per second, a mean gradient of 40, aortic valve area of less than or equal to 1, an index aortic valve area of 0.6, and a velocity ratio of 0.25. And we'll get to all those measurements in the presentation. This is the stage C of aortic stenosis, and this is the asymptomatic severe aortic stenosis that we see in the guidelines. This is defined by a Vmax of 4 meters per second or more and a mean pressure gradient of more than 40. The aortic valve area is typically less than or equal to 1 centimeter squared, or an aortic valve area index of 0.6, but this isn't required to define severe AS. And of course, stage C2 is the same, but with an EF of less than 50, and that comes back to indications for surgery. Finally, we have stage D, which is symptomatic severe aortic stenosis, and this is subclassified in 3 categories, including symptomatic severe high gradient AS, which is the AS you expect with a low aortic valve area and a high peak velocity and peak gradient, as we discussed. D2 is the symptomatic severe low flow, low gradient aortic stenosis with reduced LVEF. This is the classical low flow, low gradient. And this is when you have an aortic valve area of less than 1, which suggests severe AS, but your velocities or gradients are not reaching that severe cutoff. And the patient has an EF of less than 50, suggesting that they don't have the forward flow to generate the adequate measurements. Now, to rectify this, we do a dopamine stress echo, which, if the valve is severe, shows that the AVA remains below 1, but the gradient increases and the Vmax increases to 4 or more. And we'll come back to this later. Finally, there's stage D3, which is symptomatic severe low gradient aortic stenosis with normal ejection fraction, also known as paradoxical low flow, low gradient severe AS. And again, this is when your aortic valve area suggests that there is severe aortic stenosis. You have an EF greater than or equal to 50, but your gradients are not meeting severe criteria. And you find that you have low flow by assessing the stroke volume and finding a low stroke volume index. It's important to take these measurements with a normal blood pressure because excess blood pressure increases further afterload on the LV, which can reduce your flow. We'll come back to this as well. Assessing severe aortic stenosis is your Vmax, or your peak jet velocity, which we obtain with continuous wave Doppler, your mean pressure gradient along with the stroke volume index, and the aortic valve area by continuity equation. But how do we get these measurements? The Vmax is found using continuous wave Doppler at the maximal point. So you want to assess multiple windows, your apicals, your right parasternals, your suprasternals, to find the jet that is the highest, because you want to be parallel flow and you don't want to miss an eccentric jet. The max velocity is commonly found at the right parasternal window, and so we can't just be looking at apicals. It's also important to, when possible, report the window where you found the maximal velocity so that it can be compared on future studies. It could be helpful to look for the color Doppler alignment to try to find your orientation that's most parallel with the direction of the colored jet. It's recommended to also use a blind probe, a non-imaging continuous wave Doppler transducer, which is smaller. It can fit between the rib spaces and also has an excellent signal to noise ratio to try to find that highest velocity. And the key to this is that if you underestimate the velocity, which is squared in the Bernoulli equation, which we're going to talk about, there'll be an even larger error when calculating the pressure gradient. So it's very important to get that velocity right. And of course, every measurement has caveats and assumptions. And when measuring velocity, some of the assumptions include that it is flow dependent and it requires a parallel alignment of the beam to the blood flow. Then when we're measuring or assessing our pressure gradients, we're looking at the peak pressure gradient, but that's not used to define severe aortic stenosis, and this is determined from the simplified Bernoulli equation. And your mean pressure gradient determined using velocity time integral and tracings of the Doppler envelope. So this is the apical 5-chamber view side of the screen, and we place the pulse wave Doppler at the LVOT. And tracing the envelope to obtain the velocity time integral, the area under the curve, to obtain the velocities and flows out of the LVOT. On the right, we have continuous wave Doppler across the aortic valve, which gives us our maximal instantaneous velocity, which is your Vmax. And as well, we trace the Doppler envelope here to obtain the VTI of your aortic valve. So to get to this point, we have had some assumptions which were discussed in the physics of echo talk, so I won't go over all the assumptions to simplify the Bernoulli equation, which brings us to the delta in pressure, the pressure gradient, being 4 times the square of the velocities. And the key is that if the proximal LVOT velocity, or V1, is less than 1 meters per second, which is commonly the case in stenotic valves, it becomes even smaller when squared, so it can be dropped from the equation. These assumptions should not be done when we're including a V1 that's more than 1.5 meters per second, or when V2 is less than 3.0 meters per second. So if it is not the case, then you can drop the V1 and simply have delta P equals 4 times V squared, which is what we're going to use today. Again, the assumptions of pressure gradient is that it is flow dependent. It depends on an accurate velocity measurement, as we talked about earlier. And of course, this is a simplified equation. So with our same patients, if we use our delta P equals 4V squared, our Vmax is 3.67, which is in the moderate range, and more than 3, so we can use it in the simplified formula. We have a peak gradient of 54 millimeters mercury. But this is not what we're looking for, or when we're assessing the severity of the AS, we want the mean gradient. So to obtain the mean gradient, it's a calculation by averaging the instantaneous gradients over the entire ejection period. Luckily, it's quite simple to do this on echo because all you have to do is trace the aortic spectral Doppler envelope, and the software does its magic and does the integration for you. Next, when you're reporting your mean gradient, you want to make sure that you're also assessing the stroke volume. As we talked about earlier, you can have that paradoxical low flow, low gradient where your EF is normal, but in small or hypertrophied chambers, you can have a low stroke volume. And low stroke volume means low flow, means that your gradients might not be accurate. They might not generate enough flow to generate the pressure gradient. So with the stroke volume, the formula is quite simple. It's in mLs, or centimeters squared. Stroke volume is equal to the cross-sectional area of your LVOT times your LVOT velocity time integral, which we obtained earlier with pulse wave Doppler tracings. And finally, the stroke volume index is simply indexed to your body surface area. So for our case down below, I've plugged in the numbers, and we get a stroke volume index of 44.8 mLs per meter squared, which is normal. A low stroke volume index is defined as less than 35 mLs per meter squared, and we'll come back to this. Next is your aortic valve area calculation by continuity equation. The continuity equation is A1 times V1 equals A2 times V2 because you have preservation of your matter, your velocities, and your energy. And for velocities, we use VTI. You can actually also use Vmax. It may be less accurate depending on the shape of the Doppler envelope. And again, with every measurement, there are assumptions. The AVA is dependent on the accuracy of your velocity measurement, both for the aorta and for your LVOT. It's dependent on an accurate LVOT diameter measurement, which we'll come back to, and also the assumption that the LVOT is circular, which often it is not. And when we're obtaining diameters in echo 2D, we have to remember that this is potentially not representative of the actual 3D structure. So here we have the solving for A2, which will be our aortic valve area. A1 is the cross-sectional area, or CSA, of the LV outflow tract. And if we look here, we can see the cross-sectional area is defined as pi times your LVOT diameter divided by 2, which is squared. Your V1 is your VTI of your LVOT that we've obtained using pulse wave Doppler. V2 is your velocity time integral of the aortic valve using continuous wave Doppler, and we plug it into our formula. Before we do that, I just want to give a little shout out to the LVOT measurement, which uh, punches above its weight, so to say. This is some recommendations from the American Society of Echocardiography on how to measure it. And it's important to do this in a reproducible manner and making sure that your LVOT measurements make sense from study to study when you're comparing studies. Because as you can see, when you have a difference in the LVOT, if there's an error, the error is squared. So if all your other parameters that you've plugged into your formula are the same, a smaller LVOT diameter will give you a smaller calculated aortic valve area. So sometimes when you're looking at studies and you see that there's a big difference, a big jump in the findings from, let's say, 2 studies that are a year apart, make sure that the LVOT is not what's accounting for the big difference in the aortic valve area. So remembering to trace it in parasternal long axis, in the zoom mode, in mid-systole, inner edge to inner edge. Coming back to our formula, if we take the data from the patient that we've assessed earlier, and we plug it into our formula, we obtain an aortic valve area of 1.1 centimeters squared, which also falls in the moderate range. This person had a large LVOT, as you can see, at 2.4 centimeters. So we assessed our 3 key parameters. There are 2 additional key parameters which I want to discuss with you today, including the aortic valve area indexed and the velocity ratio, also known as dimensionless index. So for your AVA index, very simply, you take your aortic valve area that we've already calculated and you index it to body surface area. And this is particularly important in the larger, smaller extremes of body surface area. Similar to the concept of patient prosthesis mismatch, which Taylor talked about in another presentation, a smaller person may not need as wide of an opening as a bigger person. So it's important to remember to index these findings to body surface area. And here we have the cutoffs, with 0.6 being the cutoff for severe aortic stenosis. Next, we have our dimensionless index, which is also known as the velocity ratio or Doppler velocity index, DVI. So lots of names there. They all mean the same thing. And this is derived from the continuity equation as well. As you can see here, when you isolate for the velocities, you get V1 ratioed with V2. And the ideal of this is to do away with your LVOT measurements and just keep just the velocities in the LVOT compared to the velocity that you've attained with your CW of the aortic valve. And here we have cutoffs
Again, with 0.25 is the cutoff for severe aortic stenosis. Some other important considerations when you are assessing aortic stenosis. Obviously, you want to complete the entirety of the assessment of the heart in the echocardiography study, but you need to think outside the valve. So the ventricles can be affected and also can affect your gradients. The size,
thickness, and function of the LV are important to look at. Aortic stenosis, which is severe, increases afterload, which can lead to concentric LV hypertrophy as a consequence. And if you're looking at the LV systolic function, if it's reduced, it can cause low flow. A small cavity or hypertrophic cavity with low stroke volumes can give you paradoxical low flow, as we talked about. And you also want to look at the presence of other valvular disease, for example, aortic insufficiency, mitral disease, because this can affect both your assessments of the aortic valve as well as you want to make sure that you're not missing other valves that are interventionable if you're sending someone for surgery, for example. You also want to look at the size of the aortic proximal aorta, aortic root, looking for aortopathies, which is particularly important in bicuspid valves and more common in bicuspid valves, but also for the concept of pressure recovery, which we will come to. You're also looking for other potential causes of obstruction because not all stenosis is valvular. I won't spend too much time on it, but I'll just mention that there are other causes for obstruction. Might be a good topic for another day. And some of these include dynamic LVOT obstruction, for example, HCM with LVOT obstruction, subvalvular aortic stenosis, such as a membrane or muscular ridge or combination, and supravalvular aortic stenosis, which is more rare congenital narrowing, typically at the sinotubular junction, for example, with Williams syndrome. Some other important considerations when you're assessing the aortic valve is the size of the aorta. So we'll get to the concept of pressure recovery. You're looking for states of low flow, so not enough flow to generate gradients, for example, reduced EF or small, thick LV with low stroke volume. And your stroke volume is affected by your preload, your contractility, and your afterload. So significant hypertension can add a second load on the LV, which can result in lower forward stroke volume and lower gradients. You can, just like you can have low flow, you can actually have high flow, which can give you an erroneously high gradients with only moderate narrowing. For example, if you have concomitant aortic insufficiency or AV fistulas with high flow. And in these cases, using your dimensionless index can be helpful because your flow will also be increased in your LVOT. And one common cause for potential errors differentiating eccentric mitral valve flow from aortic flow because they both happen in systole. But the mitral regurgitation is longer in duration, starts with a mitral valve closure and continuing until mitral valve opening, which includes isovolumetric relaxation and isovolumetric contraction. Finally, the shape of the spectrum can help you comparing severe AS with chronic MR, but acute MR can give you a similar profile to severe AS, so be cautious of that. And of course, looking at your measurements and seeing where the cursor is pointing to. So some of the take-home points for today's introduction to assessment of aortic stenosis with echocardiography are to search multiple windows and look for the most parallel flow to assess for the highest possible velocities. This is important because the downstream effect of this is that your other parameters are mostly affected by this one measurement that you do. You need to assess the key valve parameters that we talked about, your Vmax, your mean pressure gradient, your aortic valve and aortic valve area index, and your dimensionless index. And it's important to put these findings in the context of the overall echo and the patient. So if your LV systolic function is reduced, don't forget to look and think about low flow, low gradient aortic stenosis. If you have a low stroke volume index for the body surface area, think about paradoxical low flow severe aortic stenosis at your aortic valve area suggests severe AS, but your gradients or flow are not meeting that cutoff. Important to look at the aorta, the diameter for aortopathy, which has its own set of surgical indications, as well as the phenomenon of pressure recovery, which we touched on today. You're also looking, of course, for other valve disease. We talked at the beginning of the presentation about the presence of mitral valve rheumatic disease when you have mitral valve aortic disease, which is in about, I think, 90% or so of cases is what I've read. And also thinking of things like things that can decrease your stroke volume coming out of your LVOT. So if you have severe MR, you may actually underestimate the stroke volume coming out of the LVOT. And of course, looking at the other valves, if you're referring to surgery, to make sure that you're pointing out all the different valves that may need an intervention. And for clinicians, of course, looking for symptoms. Don't forget about decreased exercise tolerance. Patients will say that they are not short of breath, but they're potentially not walking anymore because of their shortness of breath. So making sure that you're not missing symptoms because patients have become sedentary to avoid their symptoms. And of course, considering follow-up frequency. Thanks for the attention. Now have a little quiz in the form of an echo case to assess your understanding of the topic. This case is from my echo library. You can access the whole library from the links in the description. An 82-year-old male with dyspnea on exertion. Spot the findings and make necessary calculations. Feel free to ask any questions you have in the comment section below. Thank you all.